The landing, are you okay?
Tekla? Thumbs up?
Yes, we are. Thank you.
Okay,
Yep.
wonderful.
All right.
We can hear you.
Thanks. Okay, we're starting 15 minutes today late. Thank you all for your patience. We've had some new systems lately, and we're trying to make the systems better for everybody. Sometimes it impedes the one doing new things. So I'm going to pass this to you because you're going to put the PowerPoint. So welcome this morning. We have a really special presentation that I'm happy to be hosting with FNHA. My name is Lena Menifee. I am the facilitator working for UBC Learning Circle from the Center for Excellence in Indigenous Health. We are actually funded by the FNHA, so thanks for being here and for doing all the funding. But we do important circles through our work with them and in collaboration, as well as UBC and the school population and public health. I wanted to acknowledge that we're brought to you in downtown Vancouver, which is Coast Salish, unceded Coast Salish territories, which is Tsleil-Waututh, Musqueam, Squamish people. And I just want to say hi, Chika, thank you for having us. I'm Gispedwada Gihafla from the House of Weedali from up north, kind of near Haida Gwaii. And I'm happy to have everybody here who's on the panel today. I'm just going to say a few things about harm reduction and pass it over to Blake. So this harm reduction and take-home naloxone in First Nations communities. This session today, we're specifically trying to talk to people in the community and those people who are dealing with frontline, as well as health directors, people at the health centers, nurses. This is more content about sort of how to take care and the great programming that FNHA is rolling out. So we're not going to deal maybe with personal stories, although we sympathize and empathize for those stories, I have some of those as well. We're not going to deal with those today as far as like experiences. And we know that content can be triggering for some people. So I'll pass it over to Blake to kind of deal with it more, but he's the policy analysis from FNHA, and we're happy to have him here today. And you do lots of great community work too.
Yes, thanks. So my files involve mental wellness and substance use, and I work with these two lovely people who I'll let introduce in a moment. My focus is on a path forward and around the mental wellness and substance use strategy work that we do, and that includes harm reduction, which we're really excited about. So just in preparation for our discussions today, I wanted to share that if anyone feels triggered about what we're talking about, because these are issues that affect our family and our friends, our loved ones, and other community members, if you feel triggered, please feel free to step back from the session and get the support that you need, whether that's from an elder, a traditional healer, a counselor, a friend, a family member. Make sure that you take time to do that and take care of ourselves. Also, I wanted to let you know about the health benefits supports that are available around mental health. As always, the 1-800-317-7878 number, which is the general line that can connect you with mental health supports like short-term crisis benefits and IRS counseling as well, is also available through that line. They can connect you. And so I've said a little bit about myself, and I'll pass it on to Janine.
Good morning, everyone. Thank you so much for having us. Thank you to the Learning Circle. And thank you to all of you for joining us this morning, taking time out of your busy schedules and your busy lives to spend this next little hour. Thank you very much. My name is Janine Stevenson, and I have been working with First Nations community members and the various health centers throughout BC for about 17 years now. And I joined the First Nations Health Authority about a year and a half, which is very exciting because they're doing some cutting edge and transformational work, and it's a lot of fun to be a part of it.
And hi, I'm Cindy Preston. I'm a pharmacist with FNHA. I've been a pharmacist for about 15 years now and working with First Nations for about 9 years of that. I'm really excited to be a part of an organization that is where First Nations are, all the services are being transitioned to First Nations and transforming as we move into the future.
Well, thanks guys for being here. So just so you know, everything's going to be recorded today. We're on video camera. We have some video conference people. Thank you for joining. And webinar people. So the difference is video conference could actually at any point unmute their microphone and let us know if they have any questions or comments. And so I'll sort of prompt that, say video conference, do you have anything to say? And for the webinar people, I'll say, hey, you know, if you have any questions or do you want to have or throw some questions out to them, you can type into your screen in the window, and I will help facilitate and read them out. We'll have a few breakpoints, but you'll know when we ask you questions because I'll repeat a couple times. So thanks.
And I just wanted to have a question around whether we'll be able to do participant introductions today. We have a lot of people, so we might
We
not
have
be
a
able
wonderful
to.
amount of people
Yeah.
today, actually. We have about 42, and that's not including our video conference, which is about 3 or 4. So we can quickly, if people want to type in where they're from, just even like your nation or your title or like your job title, we can go ahead and do that.
Great.
Yeah.
That'd be awesome.
And maybe we could buy some time by maybe talking a little bit more about what you guys do and how this program came up. I don't know if you deal with that in the slides, so like.
We'll be going over the objectives.
Oh,
of
you'll
the
be
next
going the
step.
objectives.
Yeah.
Okay.
Absolutely.
So, but this was just rolled out recently, though. So.
It's a provincial program that's been around since 2012.
Yeah.
It's new for the First Nations Health Authority.
Okay.
Yeah.
All right. So I have some people talking here and chatting away. We have Rob, harm reduction positive wellness worker at Vancouver Island North. Jackie Bird-Sumas, counselor, health portfolio. Melanie, FNHA. Lillooet, Tigat First Nations home care nurse. Hello. Restorative justice coordinator, Secwepemc Nation, MW advisor, regional manager, FNHA. Burns Lake, MOA, Carriacou County Family Services. Thanks for joining. Raj Maharaj, Health Policy Analysis with Aboriginal Health Doctorate in Ministry of Health. Thank you for joining us today. It's pretty exciting because this content is really being honed for First Nations, which is the first time we've actually seen this kind of roll out in this way. So I'm excited you guys have done that. I kind of want to know the backstory, but you can let me know how that happened later then. If we get to
Great.
it.
Well, we look forward to meeting you all, and we'll certainly be sharing information around the session, the presentation itself, and other resources in an email out to participants after the learning circle, so you'll have access to all of these materials.
And hopefully we've given a lot of time so that if when we're done, we haven't actually satisfied what your question. I hope we've left quite a bit of time for question and answer.
Yeah, we have lots
Yeah.
of time for Q&A too.
Perfect. Okay. Well, we'll get started then. So we always start our presentations with an acknowledgement of our vision statement at First Nations Health Authority, which is healthy, self-determining, and vibrant First Nations children, families, and communities. And keeping that in mind when we're talking about harm reduction as well, that people have the right to self-determination around their own choices as well.
So this next little chunk, we're wanting to share a common definition of harm reduction with everyone. It's my understanding that the Learning Circle hosted and supported a series on harm reduction that was led by Pamela Robertson, who's a health director and a nurse herself in the Boston Bar area, and Gabor Mate. And so when we read this definition of harm reduction, if you had participated in those learning circles, you will recognize the values and the principles that were probably brought up in that original series. We also, we're going to talk a little bit about fentanyl, what it is, what it's all about, and what it's looking like in First Nations communities right now. And then the answer to fentanyl, which is the take-home Naloxone program. We're going to provide information and answer questions and answers around that. And that's pretty much what we're going to cover in this next little bit.
Perfect.
So we're advancing the slide to harm reduction right now.
Yep.
I'm not the host, so I can't. But
Yep, so we're moving on to harm reduction. So this is a definition that we found that we think is quite comprehensive, so I'll read it out. Harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on the belief in and respect for the rights of people who use drugs. So I think a lot of people are probably familiar with the first part of that, around harm reduction reducing negative consequences like HIV transmission and Hep C transmission through sharing sterile needles, for instance. However, the second piece around social justice and the rights of people using drugs is also crucially important, and we're going to really highlight that within our presentation today, talking about how important it is to connect and engage with compassion with people that are using drugs.
And we look to First Nations Health Authority's perspective on wellness. And again, thank you, Lena. I mean, it is really exciting around being able to talk about this work with sort of an Indigenous lens. I think it is new, and it's very exciting, and it is this perspective of wellness that really upholds the notion that people are valuable. They are our family, they are our brothers and sisters, they are our community members, and if they are struggling with addiction, with harm reduction, we know that they are valuable, even though that's what's happening in their lives. And in fact, we can, with this perspective, work and engage with people on all the parts of themselves. The part that is the mother, the part that likes to go fishing, the part that the addiction just sort of collapses a little bit and becomes just this, I mean, even though it's an overwhelming thing often, this perspective allows us to actually bring those other, remember that people are human beings and valuable, and we can actually connect with them around all kinds of things, and including reducing harm and keeping themselves healthy.
Okay, so then we get into what is fentanyl? What is the drug that everybody's talking about? So I guess we want to ask some questions here. And I guess those questions that we have on the slide really are, have you heard of fentanyl in your community? Are you familiar with what it's used for?
Maybe we should just start with the first
Sure,
one.
sure, sorry.
No, it's great. So who has heard of fentanyl? Do you want to put a yes or no? Just yes or no, Y or N, if you have. And we can kind of see where people are at. For the video conference, you can unmute your microphone and give us a yes or no. Takla?
Yeah.
Hi. Yeah, it's a yes? Okay, thank you very much.
Yeah.
So we have a lot of yeses coming in, so I'd say that there's about 15 yeses. So
Good, excellent.
So fentanyl is a painkiller. It's an opioid painkiller. It's actually a synthetic derived opioid. Opioids are derived from the opium poppy. They control pain, and they cause sedation and drowsiness. Fentanyl, the chemical itself, is very strong. Morphine is a very common opioid painkiller. Fentanyl is 10 times more potent. So really, a small amount of fentanyl can cure or can relieve a lot of pain. And it also has the side effects, which would be respiratory depression and that sedation. With the fentanyl, it's quite often used in settings where the pain is quite severe. So usually in cancer treatment, you would see it, palliative care as well. In prescription fentanyl, quite often we see it in the community as fentanyl patches, or Duragesic patches would be the brand name. The fentanyl that is available by prescription, but it is synthetically derived as well. So that would be, with the street drugs, it can be manufactured in labs. So I guess I kind of jumped past the next question about what does it do. Does anyone have any questions about what fentanyl does as far as an opioid or narcotic painkiller?
okay, if you guys want to type in on webinar, if you have an idea of what it's used for, what it does, or what it's meant to do, let us know. You can type in. And video conference, I can actually still hear you, Takla, so you could just let me know. What do you guys think fentanyl does? If you know, you can just pass on the question.
Well, as was said, it's a painkiller, and I think it's being used as an enhancer for street drugs use.
Thank you. Yeah, and so now if you could just mute your mic one more time for us, and then next time we get a question, we can come back to you. And I have some answers coming in from here. So a relaxer, a pain reducer.
And so Cindy has described how fentanyl is used in a clinical or a clinical setting or an acute care setting like a hospital. So it's used in procedures that induce a lot of pain, and it's very effective because you aren't actually putting people under anesthetic. But outside of the acute care setting, so in the community or on the street, it's being used in a bunch of different ways. It can be added to marijuana joints. It can be it can come in pills. It can you can inject it, and we'll get into this a little bit more later. But part of the difficulty is when it is being used in or being created in a underground lab, you never know the dose. So two people sharing the same pills from the same supplier, one person can take that pill and be fine, and the second person can take a second pill and there'd be way more fentanyl in that pill and overdose. So that's one of the huge difficulties, is not just that it's quite a bit stronger and people don't anticipate it being that strong, but it's also that we are unable to regulate how much is in whatever way, whether it's inhaling or whether it's taking it by pill.
And the other important piece on that is the fentanyl. It's tasteless, it's odorless, and it's colorless. So you'll never know if it's there or not.
That's right.
So I guess the last question on this slide is, what are some of the messages you've heard from your community about fentanyl?
So if you want to type away in webinar and let us know what your community has heard about fentanyl at this moment. It could be anything. It could be something you heard from a friend or a relative, or something you saw in a newspaper or article.
Yeah.
If you want to type away on that. Takla, you can let us know what have you heard. And Davina, maybe I'm talking more than I should. Just let me know. Could you zoom back a little bit? And I was going to be up here.
So we might be hearing different messages from community members or family or friends or from the media, and depending on what type of media source we're listening to as well, it can the message can sound a little bit different. So if you have any questions about that, or you've heard things that you're not sure are true, this is a good opportunity to ask those questions as well.
At the very beginning, Lena sort of said, what's the backstory? So fentanyl has been around for out of clinic use in community and in the streets for a while now, but its presence has increased this year. And it wasn't until the summer that it actually started getting into First Nations communities. And I now have nurses and community members talking about fentanyl in the partying circuit and scene and house in First Nations communities quite consistently. So if fentanyl is part of the partying scene in community, and we need to actually take that very seriously. If that's what people are telling us, then we need to take it quite seriously, because it's not regulated, and because we have had some overdoses now in First Nations communities.
Can I say some things that people are addressing here? Thank you so much for typing in and your answers. It's really great to hear what people are experiencing and hearing. So that it's fatal, it's causing death. Lots of recent deaths due to in the lower mainlands, which might be we might have to correct that, but causing first a psychosis break and then death. Some people haven't heard anything. One client apparently uses it for pain control. Many cases of overdose in the media. Have heard that people will put it on their tongue in a patch for a high. And dangerous overdoses, and that is really close to people in Prince George, and that is very addictive, and that's why it's being put into recreational drugs, and that it caused 20 deaths in Alberta communities.
So it isn't always fatal, but it is the main cause of overdose. And so, and again, this is why the naloxone is such a great thing, because it, as we'll be talking about in the next little bit, it's about how naloxone reverses that. But actually, people can and have ingested fentanyl and they do not overdose and die. And so it really is tied to quantity and whether you know what that quantity is. Yeah.
We'll move on to talking about opioid overdose.
So this is questions to the group. Just sort of try to do a little, just a little bit of a test on how familiar people are with overdose, what it is and what it looks like, so that we know sort of how in-depth we might need to go.
And we also wanted to be clear that this is about opioid overdose.
Yes.
So this is related to fentanyl or heroin or other painkillers that are derived from the opium poppy. People can overdose from stimulants as well, so things like cocaine or amphetamines, and they can overdose from alcohol as well. But for this discussion around naloxone, we're only talking about opioids because naloxone only works on opioids. But if you give naloxone to someone has a stimulant overdose or an alcohol overdose, it won't do anything wrong. It just won't do anything.
And I think there was a comment in the writing about psychosis. So that tends to be associated with stimulants. Very much opioids, it's about sedation. It's not about, you see that usually more with crystal meth or with cocaine or something like that.
Or if there's a chronic illness that's kind of or mental illness. Yeah.
Well, it's interesting. There's a great debate in literature out there that often says, that'll say, stimulants, because you're all full of, you're up and you're going, you don't sleep, you don't eat, and you don't drink water, so it could be the dehydration and the lack of sleep that makes you a little.
Interesting.
But who knows?
So yeah, it's complicated. But so I wanted to, can we throw that question out to the audience one more time?
Sure.
Takla, if you wanted to answer, you can right now and just unmute. Do you know what an overdose looks like, specifically with opioids only? And what is an overdose? If you want to unmute, you can, but I'm not pressuring you. Online, some people are saying here, I heard respiratory depression, cool, clammy skin, slurred speech, decreased reaction, sleepiness.
Perfect.
Somebody else is saying respiratory depression and death associated with street drug use. The first breaks were in relation to coming off and detoxing. Oh, that's a different thing. Sedation, not reacting when trying to be woken up. And blue nails, which I've never heard before.
Those are excellent responses, absolutely. Blue nails, that's like, you've come way too late, but you can get a little bit blue around the mouth. So that's right, someone may look like they're sleeping, but if you upon closer inspection, you'll notice that they're not breathing and they're not responding to you shouting, to watch out, Blake. And quite significant. You pinch at the shoulder, you can sternal rub, and they're not responding. Then you're wanting to go into the emergency procedure of responding. Yeah. So. Definitely, it's sedation and moving in deeper and deeper, where everything's sort of slowing down, the breathing's slowing down, and can stop. Often they can look like they're slumped over. Depends on where they're sitting and using, but they'll be, yeah.
Yeah, and it's something, overdose can happen whether you're using prescription or non-prescription. So whether you're using fentanyl that's prescribed or fentanyl that people find on the street, overdose can happen in both of those situations. So we have to be vigilant about the use of fentanyl, regardless of how we're using it.
Thank you. So even before using naloxone and getting to that place, if we have community members or family members that are either It's a little bit easier if it's prescription because at least you know your source. If it's not prescription opioids, you want to talk about knowing the person who you're buying your drugs from. If they go on holiday or to prison or disappear and you have a new person who's selling to you, that ups your risk for overdose because you no longer are really sure about what it is that you're buying. So you want to talk about knowing who you're getting your drugs from. You want to, and that really is about knowing the potency. And again, when it's prescribed, we still have lots of opioid overdoses with prescription opioids. But when it's not prescribed, I can't emphasize this enough. The problem is that we don't know how much is in there, and so that's that. So to try just a little bit first before you do the whole dose. So have a little taste. If you're injecting, you inject a little bit. In partying terms, that's you flag it in the syringe so that you see you're in your vein and you just try a little taste of it. And if you're okay, then to proceed after that. The other thing that sort of increases your risk for overdose is mixing substances. It's really common in the party world to drink and do coke or to drink and then do some down. And alcohol is actually considered depressant as well, so you're doubling up on your depressant. So if you're on prescription opioids and on alcohol, you've doubled up on your depressant, or like that. And you need to know that you're putting more and more on board.
So yeah, and just to say it again, the mixing the fentanyl with the street sold heroin or cocaine markedly amplifies both the potency and the potential dangers.
That's right. The other and it's quite substantiated that the other risk of overdose, of course, is when you get released from corrections or from a treatment center because you've had a long section of time where you have nothing on board, and then you bring it back on, and you're much more susceptible to overdose at that point. So it's really important to let, to talk about, again, with people who are using drugs, it's important for them to be able to be engaged with people so that they don't feel humiliated and judged, but actually are able to feel safe and to trust people to say, hey, I'm going partying tonight. This is where I'm going. To let people know, and to also, if at all possible, it isn't always possible, but if at all possible, to not use on your own. You should use with people, hopefully. Mm-hmm. It's not always possible, but yeah.
For safety.
Yeah.
I have one question coming in about the amount of mixing. Somebody asked, is it true the amount of the size of 2 grains of salt can cause death of the street fentanyl? And that's what media has been reporting. Mm-hmm. So we have to kind of address those media.
That's right. Well, the media does like to sensationalize a little bit. It's not as simple as that. Mm. Dose is also related to how much you're used to. So if I'm somebody who has been doing opioids for a very long time, I'm probably, my body has probably adapted and gotten used to high doses of opioid, whereas let's say Cindy has never had opioids in her whole life and she gets given a Tylenol 3. Well, that may affect her quite significantly where I wouldn't feel it at all because my body's quite used to it. So there's 2 things that you often hear in the media. One is it's more addictive, or it doesn't work that way. It is what you're susceptible to, and then the amount can vary. Again, it's like drinking wine. If you're used to drinking lots of wine with dinner throughout your life, and that's one thing. If you've never had a glass, it's going to go to your head. So it's like that, yeah.
And when it's not a prescribed medication from a drug manufacturer, you don't know how much is actually there. So when you see it as a grain of salt, that grain of salt may have 50% of the fentanyl. That grain of salt may be 100% fentanyl. You can't say for sure.
And then on top of it, mixing, as you said, like mixing substances, and their interactions can be different depending on the scenario and what people are doing individually.
Mm-hmm.
Yep.
So it's very complicated.
A lot of
complex.
unknown factors.
Yeah.
Well, and that's, I mean, not for today's discussion, but of course that sort of is the platform at the beginning of the conversation around regulatory mechanisms and what do we mean by prohibition and who does prohibition really serve? Because as long as we keep things underground, we don't have, there's no way to have any control over that kind of thing, around amount and around dosage and around,
Yeah, because the black market is anybody that
exactly,
can sell or slice anything together.
exactly.
So if we want to move on to the next,
Sure.
are you ready to?
Yeah, so we're advancing to the next slide. So this is a piece of an infographic that was developed by the BC Centre for Disease Control on overdose risks and signs. So this kind of summarizes our discussion. We talked a lot about knowing the risks and knowing the signs. So here we talk about mixing substances, causing dangerous effects, that if you're using recreationally or just for one time, that also may increase your risk of overdose, again, because there's been a long period of abstinence. That any change in prescription too, so if your prescription goes up or down, that's going to affect how those drugs affect you. And then using after a period of reduced or no use as well. So like Janine said, coming out of corrections or coming out of a treatment center and then using again, that'll change your tolerance. And then in terms of knowing the signs, just a quick refresh. So fentanyl and other opioids affect breathing, consciousness, and have physical signs as well. So in terms of breathing, slow or no breaths, unusual snoring, gurgling sounds, sometimes sounds of choking. And then in terms of effects on consciousness, you can't talk or walk, can't stay awake, won't wake up or unresponsive, the body is limp in some cases. And then in terms of physical symptoms, clammy or cold skin, blue lips or nails, which is really great that people identified that on the webinar as well, and pinpoint pupils as well, which is an effect of opioids on the body. And so this is just a piece of that poster that's available through the BC Centre for Disease Control. And we have a link within the presentation where you can view all of those posters and you can print them out and you can put them up in health centers or on your wall.
So we'll be sending out the URLs to you and copying and pasting if we can get this one copied and pasted into the chat. But hopefully we'll be giving the PowerPoint to everybody who registered even if they weren't able to attend today. If that's all right with you? Okay,
Absolutely.
so we'll be distributing this as well. Yeah.
So just to review, for preventing overdose, it's important to talk to people who are using opioids that aren't prescription, that they really do, to what, if the person that they're buying from has changed, to be careful, to know that that what you've bought could be different than what you're used to. Hopefully there's people that they feel safe with, that they can actually be honest with about when they're using and how much. Try not to mix substances, or if you are mixing substances, like be aware. Making a plan to know how to respond to in case of overdose, and so in a second I'm going to be talking about the take-home Naloxone program, a provincial program. Being aware of the signs of overdose, and having that plan in place. And so I guess we can go to the next slide, which is about the take-home Naloxone program.
Can I get two more questions about
Yep.
fentanyl in?
Yeah, sure.
Okay.
We'll go back to our...
Yep.
What is the lethal dose of prescribed fentanyl in milligrams? That's a very specific
Wow.
question. Thank you for those health people out there who know more than me about this. That's the first question. The second question might be harder to answer, but can someone explain how they actually melt down a patch form to produce it or inject, which I don't know how they do that, so.
Maybe we can respond to the lethal dose question. So
Sure.
around lethal dose for fentanyl, like Janine said, it's really hard to know what someone's dose is going to be to get them high or to cause overdose. It's also hard to tell for a lethal dose as well, because that depends on how heavy you are and your tolerance and a number of things. So there's not one dose for everyone. I don't know if you need anything to add to that.
When I was a nurse, I would give IV fentanyl. We'd start with 100 mils, and you talk with the person, and again, but the doctor, before they prescribed it, took all of those things that Blake just said into consideration before they prescribed what I was to give to the person. Did you?
It varies, and
Yeah.
it's you can't come up with one single dose.
Yeah.
Yeah. And then about the patch.
Yes, how is it, I guess it comes in the patch form, maybe this is the question. Is that how people get it? Is that, and how do they manufacture it?
You have a good answer.
Yeah, so the fentanyl patch has the fentanyl within the matrix of the patch, and the drug comes out of the patch and through the skin when it's used as prescribed. Now, though the fentanyl chemical itself crosses the skin very easily, so if there was just fentanyl powder around, touching it or inhaling it, it travels across the skin or mucous membranes very quickly. So the patch itself, there's lots of ways to get that drug out. Even, a used patch still has residual fentanyl within it. So that patch could be applied to skin, but it could be cut and taken out of there. There's a lot of different ways to get that drug out, but it is from the patch. It can be injected or smoked or mixed with other items.
Maybe just describe what the patch looks like a little bit for people.
Sure. So the patch actually looks like a Band-Aid. Okay, so that's how it's applied to the skin. Well, I should say it's more of a square bandage. and I would liken how it physically looks is when you look at the patch, the padded gauze part of the bandage is where the drug is incorporated into. So within that, the drug is kind of packed in that, I'd say the gauze, but it's not truly gauze. And as it kind of comes out of that,
The puffy bit in the middle.
puffy bit of the
The puffy bit in the middle.
yeah, the drug chemical itself comes out of that, and then when it reaches the skin, it's transported across the skin and gets into the bloodstream. And as it circulates around, like the opioids, they do go to the part of the brain, that's where the opioid has the effects on emotion and pain control.
Great.
I hope that answers it.
Yeah.
Mhm.
I know. I'm sorry. It's so frustrating. I know people want to know but how much is too much? But it's there's too much to take into consideration. My 2 glasses of wine are fine for me. Maybe not so much for Cindy.
It's too much for me.
As an example.
Okay. We'll move over to Take Home Naloxone. So we're going to introduce this program to you.
So Take Home Naloxone actually is very exciting, and I just want to acknowledge Dr. Jane Buxton at the BC Centre for Disease Control, and Erin Gibson. She's the harm reduction coordinator in Fraser Valley, and Sarah Young, also harm reduction coordinator in Vancouver Coastal, as really doing. Well, Erin she created the program and birthed it, and they got support from Jane and Sarah, and it's been incredibly successful. So Take Home Naloxone actually isn't way out there or new. It's actually been around in other countries like Scotland and the US and in Australia for a while now. But we launched the Toward the Heart, and Erin and Dr. Buxton, they launched it in 2012. I think it was Overdose Awareness Day in June, and since 2012, it's been the uptake has been great, and it's where we are training people who use opioids to use naloxone and to carry naloxone and to recognize the signs of overdose and reverse overdoses. So it's the training and dispensing of naloxone to people who use opioids. A little bit of factoids for you. Every year there are about 340 overdose deaths in BC. 70 of those overdose prescribed deaths 70 of the overdoses are from prescription opioids. So often people think that overdoses is because of illicit drug use, but often it's the prescribed opioids as well, and Cindy can speak more to that than I can. This year, over 180 overdoses have been reversed because of this program. That's how successful it is.
Saving lives.
It is. We have 70 sites throughout the province, and there's a picture of the map on the Take Home Naloxone website. You can actually, on that website, go in and find out where the closest site to you exists. This is provincially. We do have nurses who have gone and taken the training in First Nations communities who have naloxone on them and in their health centers and are engaged with people who are using opioids in community. But as yet, we have not matched the organization of the provincial effort. It's really good news that nurses, the College of Registered Nurses of BC created a decision support tool for nurses to do this take-home naloxone training, and they can actually become a site to have naloxone and to train community members in naloxone. And so we are just starting with that.
That's the College of...
The College of Registered Nurses of BC, so that's the regulatory body for nurses. And we have some champion communities that have already, Kate C. has given me permission to use them as an example. They, near and dear to my heart community, they have, like many communities, have many struggles around this stuff, and they have brought naloxone into their community and have taken training, and the health director and the chief and the community members are all on board and have this program existing in their community. It's quite something.
Great. So just as a quick overview, take-home naloxone is the training aspect of training people to use naloxone on themselves and on their friends and on other people using drugs, as well as dispensing a kit that includes naloxone and other tools to people using drugs. And so it's important that those nurses, like Janine said, are engaged with people that are using drugs, because it's important for that naloxone to be on the hip of the person using drugs,
Yeah.
not on the hip of the nurse who's far away.
Actually, thank you, Blake. That is like probably, if you don't remember anything else about this hour, the one take-home thing is that the naloxone really needs to be with the people who are using opioids. You have to think about it like Aaron Gibson uses the analogy like a nut allergy. If you had a nut allergy, you don't want your EpiPen in the health center. You want it on your hip or in your purse or in your pocket. And already we have had that mistake happen where a community did the naloxone training, but it's still because they weren't engaged in talking to the people, they weren't with the people when they were using. So yeah, I can't emphasize enough, you want the naloxone with folks who are using prescription opioids or non-prescribed opioids. Thank you, that's really important. Otherwise you don't save lives. It doesn't work.
Exactly.
Yeah.
So I'll move over to Cindy to kind of explain how naloxone works in the body.
Sure, so I guess maybe we should start first by, is everyone familiar with naloxone? I guess that's a yes/no question.
That's a yes/no question. So I'm going to throw it out to you. Are you familiar with naloxone at this point? If you are, say yes. If you aren't, say no. You can just put it in. I'm not going to read out your name. And video conference, if you want to answer, you can unmute your microphone right now and let us know, yes or no. I've never heard of it before this. Okay. Thank you, Takala. I had no idea when you guys asked to do this program what it was about, so we're all at different levels. We have some yeses coming in, some no's too, so.
Great.
Okay. Well, I'll try to come up with something that you haven't heard before, for those of you who are familiar with naloxone. So anyway, naloxone. Narcan is the brand name. Naloxone is the antidote for an opioid overdose. Okay, so when there is too much of an opioid, whether it be morphine or heroin or oxycodone or fentanyl, it makes the breathing slow down and stop. So naloxone reverses this. It restores normal breathing and it brings back consciousness. Okay, so naloxone definitely prevents that any brain damage from the lack of oxygen. Okay? Again, naloxone only works for opioids. It doesn't work for GHB or ecstasy or cocaine. When there is multiple substances being involved in the overdose, naloxone can still be used. It removes the opioid from that overdose. So that's a little nugget.
It's an important nugget.
It is an important nugget. It focuses the effort on the other life-saving measures that can be done and administered. Now, naloxone now on the Canadian market is only available in injectable form. So it is a little ampule that needs to be broken, brought up in a syringe, and then injected.
Do we have that kit syringe?
Well, no, because today is not the training. I mean,
Okay.
really.
We have the picture on the side.
Yeah, exactly.
Okay.
You know, the good news is nurses use these ampules and inject all the time, so it's kind of old hat for them.
Yeah.
And for people who aren't familiar with ampules and injection, you want to do a face-to-face training because you're talking about recognizing overdose and you're talking about
How to safely break an ampule and how to draw it up in a syringe.
and we use oranges so you can feel what it's like to go through so it's a whole thing.
Okay, just checking.
Yeah, and that training is available at those harm reduction sites that are on the Toward the Heart website. And it's also will be available by nurses who have taken the training as well, who can train other people. And so there's a lot of efforts going on within First Nations Health Authority around that.
And the three of us, well, we're jumping way ahead here, but the three of us are here to support people who want to, who have more questions or want to move forward with their community. I mean, that's what we're here for.
So it's more like a vial then, if you could just, for layman people.
Yes, of course.
Yeah, it's a vial, not like an EpiPen, which is
No.
a different.
In Canada and BC right now, it's a vial that you would draw out of a syringe. In other areas, it is available in other formats.
And they're working very hard to actually change that.
Interesting.
Yeah.
So we'd expect in a year to few years, we will see other forms of naloxone on the market, which will be easier to use.
Yeah.
People are very interested in this, the form, so, and maybe why not preloads? I don't know what that means.
Yeah, so really naloxone right now is only available in this little vial form. But as this is, naloxone saves lives, it's easy to use. So having easier ways to get that to the people who need it is what governments and drug manufacturers and healthcare providers and the individuals at risk are looking for and need.
And it's what we're advocating.
And to be rest assured, so Dr. Jane Buxton is leading this fight. Actually, it's not really a fight, but she's actually moving those regulations and supporting research that is looking to change not only how it's being given in the vial form, but also to make it more available to people.
Mm-hmm.
Yeah.
So there will be changes in the near future, hopefully. So with the naloxone, how it works is fascinating. I love this area. The naloxone works, what it does is it removes the opioid or the narcotic from the receptors. So really what that means is it stops that narcotic action that's happening. It really reverses the effects of the narcotics. Now, the naloxone only works, the action is quick. It starts working right away, so the effects are quite dramatic quite quickly, but it doesn't last. Okay, so the overdose can reoccur because there's still narcotics and opioids circulating in the body anywhere after half an hour. So that's why when we talk about reversing the overdose, this is a great drug, but the other measures have to kick in, calling 911, and get that, what is it called, a stream or steps.
Yeah, it depends on how rural and remote you are. So each community is going to have its own its own plan about emergency response. Actually, a lot of communities have engaged in the first responder program, which is incredibly exciting and wonderful. And that planning and that work actually could easily support a take-home naloxone program as well.
So one of the questions that we'll probably have is, naloxone. We're saying, get it out there, have it everywhere, have it where people are using. But there's questions usually around can naloxone be harmful or abused? So the really nice thing about naloxone is it's very, very safe. If there's not narcotic in the individual or opioid in the individual, it's not going to do a thing.
Cindy could put naloxone in my body right now and nothing would happen. It would be, you can't make a mistake with it. You can't give too much, you can't give it for the wrong substance. It's like safer than Tylenol.
That was like 3 people asking that question, so. What's the safe dose level? What's the side effects?
Yeah.
And then like, why aren't they looking at preloads? I think that was, so we're covering it.
Preloads and inhalation. Inhalation naloxone. We should be asking and demanding for inhalation naloxone.
So letter writing is.
Yeah.
Letter writing is really important because we actually have first-time responders that will have regulation that dictates what they can and cannot do. So you get and so I'm talking about like firefighters, for instance, aren't allowed to give injection. If a firefighter is the first person to show up, we want them to be able to give the naloxone. So there's still advocacy that has to be at play here for sure.
And I guess to naloxone, one of the major questions of what is naloxone is it is a prescription drug right now.
Yeah.
So when we talk about the new forms that might be coming out on the market in the near future, we are also looking at naloxone changing from being a prescription drug to an over-the-counter drug, where it doesn't require that healthcare professional intervention to obtain.
Much like EpiPens, if you think about that.
Yes.
So, a parent would be able to buy an EpiPen for a child. Someone else would be able to buy naloxone for someone else's use.
Although we don't, that's all the good news about naloxone. Naloxone is a provincial program. You do not have to, health centers and health directors do not have to worry about buying naloxone. It is a provincial program. When you take the training or your nurse does the training and signs up to be a naloxone site, it is provided through the provincial program.
Completely free through their formulary.
Yeah.
Good.
I think somebody's curious about injecting into a vein or where do you inject it into? So.
Well, sorry.
No, go ahead.
There's lots of really great training that's available for this, so we're not going to go
Should I put up
through.
some? Yeah.
It's a muscular injection, so it would go into
muscular,
the
okay.
thigh, into the butt, into the top of your shoulder arm.
You need a muscle. Don't worry about clothing. Just like if you are concerned that someone might be on an overdose, get a nice meaty area, as meaty as you can, and inject it.
And don't worry about bubbles too. Some people are worried about bubbles within the vial,
Yeah.
and when they're drawing it up into the syringe,
Yeah.
and because it's going into muscle, it's not an issue.
Muscle just absorbs the oxygen.
Great. Thank you for answering that question.
Great. So we're going to move on and talk about take-home naloxone in community. So talking about how First Nations communities can get connected with this program and train nurses.
Right. So we do have some First Nations communities, their nurses specifically, who are talking and engaging with people who use opioids. And in fact, in 2 communities, it was the community members that asked the nurse about it, and the nurse took the direction from the community member. And usually what happens is I get a phone call, and it's important also to sort of emphasize that we are here for support, but I also put them in touch with the local resources to support them. So for example, on the island, if a First Nations community, the nurse wants to sign up, she can, or he can go through the training online. And there's all kinds of videos and resources and literature to support that nurse. Again, though, the three of us are here, and then it can look like a couple of different things have happened. I have put them in touch with the regional harm reduction coordinator so that he or she can get them familiar with the sites that are around them. But then also that we can do a variety of face-to-face meetings or trainings. We have gone to trainings on the island, which were a mix of nurses from First Nations communities and the local public health nurses, which is really great as well, because they're much more networked and supported. So it's not just the nurse in the First Nations community, but it's the nurse down the road in the municipality as well. And it just brings everyone together so that those resources and those supports are right there for you. The next piece, I think, which again, right now we have to work on a sort of a community by community basis, but often nurses or community members who have taken the training for naloxone like to have additional support in it's like the train the trainer, right? So they now have the training and they would like to train others, but that's a little bit harder. So again, the regional harm reduction coordinators, myself, Blake and Cindy would be available to support that community member or that nurse to then give additional training in the community.
So that's wonderful, and we'll give your contact information hopefully at the end of this to everybody so they can contact you about that.
Yeah.
So there's a couple scenarios. So in a transferred community, nurses would need health director support to implement the take-home naloxone program, because the health director is the employer. So the employer would have to say it's okay to do take-home naloxone in the community, and then they could access the training and dispense naloxone to people using drugs in community. If nurses are employed by FNHA, they're supported to deliver the program, and of course it's recommended that FNHA nurses seek community leadership support for take-home naloxone so that they connect with the community about implementing this program. But First Nations Health Authority supports this work moving forward. And we have a sample take-home naloxone policy from Island Health and from FNHA that we can share out to participants if it's requested by a health director that they would like a formal policy within their manual around take-home naloxone, that we can provide a sample to adapt or change or just review. And then there's an image on this slide, the overdose survival guide, and we've included a link to the overdose survival guide in the slide notes as well, so you can access that resource for free. It's through the KD website, which we've also linked to, where you can get free resources around harm reduction, Hep C, and HIV, and they can be delivered to your community completely free.
And just a word about getting community leadership and your health director on board. As you are all very aware, addiction is layered and complicated and can be very painful and highly stigmatized. And often people worry about how to start to have conversations in the community around naloxone. And I am here to tell you, in my experience, when you bring the take-home naloxone program to your community, what actually ends up happening is it provides this incredible safe space to start those hard conversations with your community members. Because basically what naloxone does is it tells people that they are valuable and they are being cared for and their lives are precious and need to be saved. And so when you start a hard conversation with that message, it's quite powerful. And I can't emphasize enough. The program is this very safe conversation starter and opener. It holds the conversation in a really good way.
And we were so grateful to have Pam and you guys today, of course, bring out this harm reduction kind of view that Pam Robertson and Jerry Ullman, which we have that video of when they were talking about harm reduction 101, were talking about what harm reduction looked like pre-contact, and that people were valued and that lives are valued, and that this idea is not outside of Indigenous knowledge scope or outside of our community's ideas about people. It's actually within to like hold people.
One of the community members that I worked with it was so interesting. Throughout the entire training and time, not a word from him. And we hung back because sometimes it is too hard to speak out in a group, so you just hang back and wait after it's all broken up. And he presented himself right away and said, I want this training. I want to be able to use naloxone, so that he could tell his niece that he loved her.
It was really powerful.
Yeah.
It's very powerful. Way to start that conversation.
Yeah.
So lots of respect to people doing this hard work and wonderful work, and thanks.
Yeah.
It's a good story.
Yeah.
So we wanted to talk a little bit about the kits themselves, and again, answer any questions.
Yeah. So far, is there any?
Yeah, there's lots of things happening. This is a very engaged audience. Thank you, everyone. Takla, you can obviously come in whenever you want to if you have any comments or questions too. Please feel free. So about the sample policy, is it okay if I email that out with the PowerPoint?
Absolutely.
Okay, wonderful, because people are asking for that.
Mm-hmm.
Also, how long is the training? Just like a practical question. And is this just in BC? Or is it across Canada? CHNs can dispense naloxone in 6 communities. I don't know what that's a commentary question. So.
That was in BC. That was a line on one of the slides.
Yeah.
So far we've connected with 6 communities around take-home naloxone.
That's First Nations
First
communities.
Nations communities.
Through FNHA.
Through FNHA.
Okay.
Yeah, we don't have.
Well, 3 connected through the regional harm reduction coordinator, but that's just because they're awesome. The training can be, again, I don't have an exact answer because, if it's a bunch of nurses in the room, it can be as long and as short as you want. I mean, one training, they provided a meal. We took the actual instruction time took maybe a little longer than an hour, but that's all. The other thing that's really fantastic about this programming is you with us can decide how you'd like that to be held and how the actual this is what an overdose looks like, this is how you open the vial. That doesn't take very long at all. That's like a 45-minute or an hour moment. Sometimes we've had community want to open up the conversation past naloxone to try and bring other harm reduction measures to the community, and so that conversation is a longer conversation. So it really, the instructional piece itself, not that long, but it really is to be designed the way that makes the most sense to community.
Mm-hmm.
Right. So you can modify and specify it. I put up a few links of some trainings, but in the urban area. So there's some at UBC, there's some that you mentioned before. There's
as Blake was mentioning, the sites, like when you go on the website and you click and you see where a site is nearest you, they can train. They can train. If you get in touch with the regional harm reduction coordinator, each health authority has one. So let's say someone from the Interior phoned Jeff Walsh, who's the harm reduction coordinator for the Interior. Usually he'd get on the phone to me right away, and then the conversation would be immediate. It would be the nurse or the community member or the health director, myself and Blake, and we would again, it is driven by the community ask. Yeah.
And all of that information is available in the presentation that we'll share with you. We have all the contact information for the regional harm reduction coordinators, as well as for our own FNHA regional mental wellness advisors, as well as contact information for Janine, who's the lead for this program. So that'll be available to everyone.
Oh, yeah, we mustn't. And that, just a shout out to the mental wellness and substance use advisors. I think I've met almost all of them, and they have the most passion and the hugest hearts, and they're incredible resource as well, and are hooked into the harm reduction work and this work as well. Yeah.
Great. So in sharing information about the kits, we wanted to be very clear and let you know that if you're working in a health center or you're a nurse yourself, tell the nurse or go to the Take Home Naloxone website to access the training, to find a site, and to register your Take Home Naloxone site, so to register your community as a site that delivers Take Home Naloxone. It's a very simple process. All of the forms are on that website, and they do have staff support that you can call to help guide you through that process as well. And you can, of course, connect with us if you have any questions.
And I'll just say, just for a practical tip, for registering a site, before, like from the time you register to where you actually receive kits that can be dispensed, that could be a 4 to 6 week window.
Good, thank you.
So just to keep that in mind.
There might be an opportunity for you to bring, if there's an immediate need,
Yes.
to bring those community members or health staff to a site to be dispensed naloxone to themselves as well. So you're not waiting. That's important.
And that Toward the Heart website, the posters, videos, information, data, if you need data to support a conversation with leadership, it's a very thorough website. Yeah.
Totally. So I'm just putting up the slide on staff support. I don't know why it's not showing up so well. Maybe it didn't load correctly. We'll make sure that the slide works for when we send it out. The most important contact is Janine at the top in green, and she's legible up there, so that's good. And then we've listed the regional staff that are also available, and we'll connect you with them as well.
We have time for more questions and answers?
I think we have a few minutes to take some questions and answers, so let us go ahead and do that. Video conference, do you have anything to say? Any ideas, any feedback?
And just I've switched to the additional resources slide, so that includes the Toward the Heart website, as well as anonymous non-emergency assistance. So we certainly recommend that people call 911 in the event of an overdose. However, people may prefer to call the Drug and Poison Information Center or Health NPC as well. So we've included these as well for information. Good to share.
So I'm just putting up Janine Stevenson's contacts right now.
Perfect.
Is there any Q&As on webinar? Do you have any questions, comments, concerns, anything that you would like to know? I have some thank yous coming in, very informative. This is all new stuff for a lot of people, I'm sure. And so there's 6 First Nations sites now. Do you guys have a goal? Is there an idea of how many? Because I mean, we have a lot of, like 271 in BC, the villages at least. So is there an idea that where FNHA would like to see this, or how many places implemented?
It would be wonderful if every community would like to implement this, and we'd certainly support every community too. The way that we look at harm reduction through First Nations Health Authority is that we provide information and resources and support, and it's up to communities to decide how they want to address harm reduction, and if that includes take-home naloxone or something else, we support those decisions, but we're here to provide that information, to provide those connections to people that are working in the regions. But we're certainly not telling people that everyone has to or mandating it in any way, but we're certainly here to support communities that are choosing this.
So I look forward to the copy of the PowerPoint and the links, as well as sample policy. Thank you so much. I've learned a lot from this session. I love these FNHA webinars. It's great to hear. Because we're doing a lot lately. 3 a week come back tomorrow for midwives and doulas, actually, and then we'll be taking a week break, and then we have a full November, 2 a week. So yeah, always bring your friends, tell your family. Looking forward to more information. I have just a last minute question too. So you're talking about naloxone going to communities first, but then for people to keep it on their person as well. So how does that happen if it has to go through? Is there anything you can has to go through the health center and then the nurse, and then how do you get it on people's person? Is this a good question?
Yeah, sure. I guess we could, again, Kate gave me permission to talk about what happened in their community. It was great.
A story, okay.
Yeah. It started out with a community member, the chief, and the health director asking us to come and provide a community forum. And again, we did the training, but it was mostly focused on more sharing of information and just sort of keeping it driven by the community members and what they were wanting to know. We did include the training, the 45-minute training, and people have to sort of present to me that they are using opioids, and that can sound like I take Tylenol number 3s all the way to I party every night, and then we went back, and once that meeting happened, there was the second ask was much larger, and it was and so nurses and community members or parents, aunties or uncles, as long as it's understood that it does need to be with the person who...
Your conference is scheduled to end in 2 minutes.
Oh.
Horrific. You can keep going.
Okay, so basically it's like that, I'm going to age myself, but that shampoo commercial, you tell 2 friends and they tell 2 friends and so on and so on and so on. But basically we have a dad who wears the naloxone kit around his neck. And his daughter lets him know when she's partying, and he gives it to her. There's people who have it in their home because that's where the partying is taking place. It can look like so many different things.
Mm-hmm.
Really, it's and again, that's why naloxone is so wonderful to support those hard conversations. Is because you do. If you're the one that was trained, you do need to go to the person that you're worried and care about and say, I have naloxone. I can show you how to inject it. Yeah.
Yes, here it is.
Here it is.
Take it with you.
So currently, the naloxone needs to be procured from BCCDC, from the BC Center for Disease Control, makes its way to the health center. The nurse dispenses it to someone with past or current opioid use. And then that person can use it on themselves or on others. Ideally, like Janine said, it's important that they're connected in with people who are using drugs, so that it's as close to their hip as possible.
Exactly. And again, it's driven by the person who is using substances. So if it makes sense for them to keep it with their uncle or with themselves, it needs to make sense to the person who's using the opioids.
Well, thank you for ending on that compassionate note. It brings a lot of empathy and a lot of thought around this.
Thank you for having us.
Thank you so much, you guys. Thank you for Davina Ridley, for Shauna Duncan, for David Anderson, for behind the telehealth, as well as Stefan. And thank you, Takla, for coming and joining us. We'd like to see you back again. This has been a great session, and as again, we'll email you all the things that we talked about today and get them to you.
Yes. All right. Thank you.
Bye, everyone.
Thank you.